So again, no disclosures from me. Clinical question was raised: what is the optimal treatment for a recreational athlete with an acute Achilles tendon rupture? So actually, there is a disclosure I should make. I am not an expert in Greek history, but a little research will tell you who Achilles was, if you don't already know. He's the legendary Greek hero of the Trojan War. He defeated Hector. He's the central character in Homer's The Iliad, who's said to be invulnerable due to a coat of armor, which he got as his mother, Thetis, dipped him in the river Styx, holding him by the heel. So he was eventually mortally wounded by an arrow to that heel. And here you see Thetis dipping infant Achilles into the river Styx. This is Achilles at war, in the Trojan War, and here is the statue of him with his mortal wound to the Achilles, and some would argue that he probably died of an infection. Question is raised, though, is that arrow to the heel the same as slicing the Achilles, and are either of these the same as what our athletes suffer, and will they or will they not return this? Briefly, a little anatomy here. So the Achilles comes from three muscles. In case you don't recall, you have your medial and lateral heads of the gastrocs, superficially. There are two heads right there. One on the medial head and the lateral head. Remove that and you see your soleus deep to the gastrocs. So the three heads come down to form the Achilles. Talking about the watershed area, which I will point out again in a moment. So it's the triceps surae, which is Latin for three heads and of the calf. All right, so Achilles tendon rupture. It's a relatively common injury in adult male athletes, typically the weekend warriors in their 30s and 40s. Much more common in men, 10-to-1 ratio. As most of you probably know, it's typically a non-contact injury. Patients hear or feel a pop. Depending on where they come from, sometimes they think they were kicked in the back of the leg, sometimes they think they were shot. They have pain, they can't return to play, but they usually or often can walk off the field. We mentioned the watershed area there. So some theorize that there is decreased blood flow to the area between 2 and 6 centimeters from the heel cord insertion, and this is the area where the injuries most commonly occur. Some have theorized that there is pre-existing tendon degeneration, and a small portion of patients do have prodromal pain before they actually rupture, but that is the minority. The injury can occur more proximally at the myotendinous junction. More fortunate if you get a gastroc rupture, it can occur distally in a volus off the calcaneus. So the workup includes the history, usually the age of the patient, the mechanism, whether or not they return to play. You can gain a pretty good idea whether or not they tore their Achilles. Time frame does matter in terms of how we treat it, like I mentioned them earlier. The exam, swelling, ecchymosis, you should be able to palpate a tendon gap if it's a full tear. I think it's important to note that the motor function exam can be normal. Patients typically can plantar flex and dorsiflex their ankle, but they do have an abnormal Thompson test, which I'll show. Imaging is important, very important actually. Before you proceed with surgery or before you decide on your plan, you need to ensure that there's no bony avulsion. It's nice to know if there's some pre-existing tendonitis. I don't think an MRI is necessary, but it can be a good tool if the diagnosis or the location of that injury is in question. So here's our patient. The injured side is the left. It's assumed the dorsiflex position, and the patient's in the prone position, obviously. swollen, you don't see the contours of the Achilles very well. They probably will get ectomic in a day or two. Here's our Thompson test. I'm assuming most of you use this, but I threw it in here to make sure we know what we're talking about. This patient I saw a couple months ago. This is the well leg, okay? Squeezing the calf and their plantar flexing towards the ceiling. This is about a week after injury. Squeezing the calf and if anything, just dorsiflexing. So, positive Thompson test. I would actually call it an abnormal Thompson test. It gets confusing sometimes if you say it's a negative Thompson test. I mean, they can't do it, or positive. So, abnormal Thompson test. X-rays, as I mentioned, are important. You don't want to miss that. That's a surgical, almost a surgical emergency. That bone presses on the very tenuous skin in the back of the heel, and that can cause necrosis of that skin, and that can have a very bad outcome. You don't want to miss that one. Okay, we fix these differently. That gets a couple of screws, and it's a different recovery. MRI, as I mentioned, sometimes we get these, not too often. Pretty clear there's a disruption between the Achilles right in that watershed areas. What are the treatment options? You can treat these non-operatively, you can treat them operatively, you can treat them with a cast, you can treat them with a boot, non-weight bearing versus early weight bearing, you can mobilize them early, you can treat them with percutaneous repair. There are a variety of options, some of which are shown here. These are the surgical repair techniques. Most commonly, it's a fairly big incision, maybe not that big, but end-to-end repair with locking sutures. This is a crack-out suture technique depicted here. There's a variety of suture options that have been described in many different articles as to which one's superior, but none are conclusively better. There's a percutaneous technique visualized here, but the real question is, do we fix these or do we not? And the considerations are, what's the healing rate? Is it the same if you repair it or you don't? What's the re-rupture rate? That's one of the biggest concerns. Also, do they return to their sport, or do they return to their normal life? When, and what are the complications? This is what you want to avoid. This is a disaster. Fixing this with staples wasn't the best idea, but really, you never know who that's going to happen to, and that's a nightmare for the patient and the surgeon. So historically, both options were considered reasonable, but the test answer, at least when I was training, which is getting longer and longer ago, but 15 years ago, the answer was non-operative treatment has a high re-rupture rate, operative treatment has a high infection rate. And these you can see were treated with non-weight bearing for a variety of time, both operative and non-operative. Re-rupture rate definitely lower in the operative group here. So what does the evidence these days tell us regarding operative versus non-operative treatment of Achilles tendon ruptures? A PubMed search of relevant level 1 to 3 articles was performed. We mentioned levels of evidence previously. For some reason, Achilles tendon ruptures have better evidence than a lot of the stuff in orthopedics. For many years, orthopedic literature is filled with very poor evidence. Case series, cohort studies, levels 3, level 4, expert opinion, but very few level 1 studies. Nowadays, we're getting a few more level 1 studies, and the Achilles injury appears to have a fair share of them. So, back in 2001, Bandari performed a study, a meta-analysis of a large number of patients. These were treated with operative versus non-operative. They were all treated with a cast. And here's where some of the data from the re-rupture rate comes from. If they were treated with surgery within a cast, they had a 3% re-rupture rate compared to a 13% in the non-operative group. Infection rate was not insignificant. As I mentioned, that's a disaster. Despite all that, surgery was generally recommended, but importantly, they did not define exactly what their post-operative protocol was in terms of weight bearing and in terms of range of motion after the surgery. The same year, Mahler had a level 2 prospective study comparing operative versus non-operative. This is a level 2 study, so it's considered a good study. And this is where this 21% re-rupture rate comes from. Okay? The operative group had a much lower re-rupture rate. But this isn't comparing apples to apples. I don't even think it's really apples to oranges. It's The non-operative group was kept in a cast for 8 weeks, and they're now weight bearing for 4 weeks. The operative group was in the cast for 2 weeks, and they're allowed to weight bear, and they're allowed to rehab the Achilles pretty soon after the surgery. And we're going to see that that seems to be what makes a difference in whether or not the patient re-rupture. So this is a level 2 study that you can't really use to dictate how you treat patients. So Twaddle's study in 2007 was somewhat of a landmark study in that they had a level 1 randomized controlled trial. All patients were treated with early range of motion after being in a splint for 2 weeks. So you put the patient in Aquinas plaster, meaning foot pointed towards the ground, for 2 weeks, and then they are, after surgery or no surgery, they're allowed to start early functional rehab. And what that meant was just sitting on the edge of the bed, letting their foot dangle, and then bringing it up to neutral and letting it drop. Bringing it up to neutral, letting it drop. They did that 3 or 4 times a day for like 2 minutes. That's all they did. They were non-weight bearing for 6 weeks. They had 42 patients with pretty good follow-up, 1 year follow-up, and they found no difference in the total number of re-ruptures, and no difference in functional scores, and they didn't have any difference in significant infections. So their conclusions were that controlled early motion is the most important part of the treatment of the ruptured Achilles tendon, operative or non-operative. And they found that this controlled early motion was safe. So that was very important. That was new data for us, but it shouldn't have come as a surprise because Gelberman of hand surgery fame back in the early 80s performed a study in dogs determining whether or not early motion is safe. They had early protected passive mobilization, and they determined that this augments the physiological processes that determine the strength and the excursion of a repaired tendon. When you think of the tendon structure, with the collagen fibrils arranged in a linear pattern, it starts to make sense that early motion should help. So we have our collagen fibrils, and here's an example of an injury where it's a bunch of scar. When the Achilles ruptures, it ruptures, and if you open it up, it's a scar ball, right? Compared to our normal structure on the right. And you can imagine with early motion and allowing those fibrils to sort of stretch out and resume their normal configuration, we may get more normal function and strength afterwards, rather than putting someone in a cast for 8 weeks where they get this scar ball here. How strong is that going to be? So it makes sense, and it appears to be safe to start early range of motion. How about weight bearing? In 2008, Sukak performed a level 1 study comparing early weight bearing at 2 weeks versus delayed weight bearing at 6 weeks after surgical repair. These are all operative patients. They had no difference in the number of re-ruptures. Impressively, they had none. They also had no infections. You almost don't believe the data because everyone did well. They had a better early recovery in the weight-bearing group, which is something that people are starting to study a little bit more. How do these people do in their activities of daily living? How did they do socially? When did they get back to work? Not just when did they get back to play? And this group did better when they weight-beared early. I think the one fault to this study is that it's only 6 months follow-up, so you really don't know if people ruptured in a year when they got back to, say, their sport. But based on this, they determined that early weight-bearing appears to be safe, at least in the short to mid-term. So Willits compared operative versus non-operative with early weight-bearing and early PT. They had a decent number of patients, operative and non-operative, and both groups were allowed to weight-bear early at 2 weeks and start early range of motion. They found no difference in the re-rupture rate, still relatively low. That's considered a pretty low re-rupture rate. They found no clinical importance between the groups, and so they determined that non-operative early weight bearing with early range of motion is a good option in some of their patients. A few more studies here. A study out of Sweden, another level 1 study. So you're seeing we have a lot of level 1 data. Not all of it's perfect, but it is level 1 data to help us with these decisions. 1 year follow-up, non-operative, were allowed to weight bear in a booth for 8 weeks. They did not do any early range of motion exercises, and they had a 10% re-rupture rate. So right here you're thinking, maybe it's because they didn't do that early range of motion to allow that tendon scar ball to sort of to heal in a better position. The operative group did better, but they were allowed to start range of motion early at 2 weeks. They had no re-ruptures. We do make a distinction between superficial and deep infections. The superficial ones, they worry you. You put them on oral antibiotics, see them in the office frequently, they do okay. The deep ones are the ones that are really a problem, that need additional surgery and plastics coverage, and that's a real problem. So they didn't have any of those. Importantly, neither group was 100% at a year. Half of them did not return to play by a year. The operative group did a little bit better with functional testing at 12 months. So what can we say? Putting all this together, it appears that non-operative treatment of the Achilles rupture with early range of motion and early weight bearing is probably safe, and it's probably as effective as operative treatment. But let's wait a minute. That's what we thought about a year or two ago, and now some more studies have come out questioning some of this a little bit. So in 2014, most of these good studies, for whatever reason, they're done in Scandinavia or other parts of Europe. Not that many are coming out of the U.S. Another level 1 study with 1 year follow-up. They were allowed to weight bear very early, day 1 or non-weight bearing. Early range of motion for both groups, same way that I described before. They found no differences in outcome, but a pretty high re-rupture rate, which is a little concerning. These patients also didn't do that well at 1 year. It was hard for people to return to play at a year. One more study. This is the most confusing of all. These patients were treated non-operatively. So a level 1 study, 2-year follow-up. Okay, they were placed in a cast for 8 weeks. Some were allowed to weight bear right away. Well, actually, no. Some were not allowed to weight bear for 8 weeks. The other ones who said they had early weight bearing didn't say exactly when. These people did pretty well. So they didn't get early range of motion, which we thought was important. They were allowed to weight bear in one of the groups. The other group wasn't. The other group got non-weight bearing, back to the old days, non-weight bearing and no early range of motion, and the rupture rate wasn't so bad. So maybe it's not the early range of motion according to this study. There were some funky patient selection criteria that put this study a little bit into question despite it being a level 1 study. So, some of our conclusions. The evidence is not clear that it's the early weight bearing or the early range of motion that gives modern day non-operative treatment good results. Regardless, most studies suggest non-operative treatment with early range of motion and or early weight bearing appears to be a very good option. Just to study exactly what that protocol should be, you can say all this, but then you get this patient in your office, and whether you've operated on them or not, for the first time when you let them walk on it early instead of casting them for 6 weeks, or you let them start range of motion early instead of casting them for 6 weeks, it's pretty nerve-wracking because you're worried that they're going to rupture this. And in fact, most of the studies show, a lot of these studies were only 20 patients, 40 patients, so there's only 1 or 2 re-rupture difference in the outcomes. And it's oftentimes something stupid where the patient re-ruptures. They missed a step, they slipped on the ice. One of the studies had a guy who got held up at a gas station and he re-ruptured his Achilles. It only takes 1 or 2 of those to skew the results. But it makes you worried about doing this. But anyway, this guy Bruman performed a nice systematic review of what to do, at least in those we've operated upon. And he says that immediate full weight bearing leads to higher patient satisfaction. And what I mentioned before, that earlier social recovery, earlier return to work, earlier return to play. Okay? All functional parameters favor full weight bearing, but the statistical significance in this review was not really there. There wasn't an increased rupture rate in early weight bearing. So they can weight bear early, according to him. And early range of motion was superior to cast and mobilization for the functional reasons and didn't seem to cause an earlier re-rupture rate. These are my protocols. These are on the compendium. This is sort of a moving target with the literature that comes out. But in general, both my operative and non-operative protocol, I keep the patient in the compliance, splint or cast for about 2 weeks, with non-weight bearing for about that long, 2 weeks. If we operated on them, we take their sutures out at about 2 weeks, and then we start weight bearing. At about the 2 week mark, I do weight bear them, but I protect their weight bearing. So you're protected weight bearing with crutches. They're allowed to put weight on it, They're in a boot. We start the early range of motion, but we protect them for those first 4 weeks, maybe to prevent that slip on the ice or fall down the stairs. Same thing for my repair guidelines, very similar. Again, this is a moving target. Finally, anecdotal evidence. I call this level infinity. My 2 med school roommates are both orthopedic surgeons. One of them is the team doctor at USC, Southern California. I talked to him about this. He says that athletes need restoration of tension, so he fixes them all. He also says that in LA, it's a lot harder to talk people out of surgery, so everyone gets fixed. He agrees that this is not following the literature. My other med school roommate is in Flagstaff. He's a recreational outdoor athlete. He tore his Achilles. I think he was trail running when he did that. He treated it non-operatively with early weight bearing and early range of motion. He thinks he's done well, no pain, no problems, he jogs, but he hasn't sprinted or jumped. With these results, he recommends non-operative treatment for recreational athletes, but he doesn't know the answer to those. So summary, based on this review, Achilles ruptures may be treated non-operatively. Operative treatment is an option, but wound infection remains a risk. Re-rupture risk seems to be diminished with early range of motion and early weight bearing in non-operative, and I would say operative patients. So we think those should be included in your protocols. Regardless of treatment, a large number of athletes never return to a prior level of play. So the clinical question was, what is the optimal treatment for a recreational athlete with an acute Achilles rupture? In my practice, a recreational athlete gets non-operative treatment with early protective weight bearing and early range of motion. Some of them, however, can't be talked out of surgery, so if operative treatment is chosen, early weight bearing and early range of motion should be utilized. Thank you.
Any questions?
Dr. Swan,
Yes.
is the tension that's on the gastrocnemius, when you have a ruptured Achilles tendon, no, I'm thinking about like the hand or the fundus rupture, that muscle, the gastroc muscle, doesn't coil up high into the calf where you have to then and surgically fish it down. Because I had a 52-year-old recreational athlete a couple of years ago who tore his Achilles tendon, and his doctor did it non-operatively, and that was the first time I ever heard of non-operative treatment. I thought the guy was nuts, but you know, here we are 3 years later, and knock on wood, he's doing great. So, and I'm always thinking that if you rupture the Achilles tendon, that gastroc is going to recoil back up into the calf. That's not the case.
You know, I've heard that forever over the years. That's what happens.
Right.
It does retract a little bit,
Okay.
but when you operate on them early on, we like to operate on them in the first 2 to 3 weeks, and there's a little gap, maybe 2, maybe 3 centimeters, but it doesn't go all the way back up into the calf towards the knee.
Okay.
If you get to them late, if you're going to treat them non-operatively or operatively, when you get to them late, and late being a month, 6 weeks, it does present a problem because it's retracted a little further, and it's harder to fill that gap. So sometimes you have to do muscle transfers, muscle turn downs to fill that gap. But part of the reason we put them in the equinus position is to help relax that and bring that gap closer together.
So the gap is only like very small.
It's small.
Oh,
Yeah. Someone else has a question?
About the infection rate, is it because it's so far from the heart? Is it because everybody has infection rate when they're surgery? What is
It is a high infection rate for the surgeries that we do. I think Dr. Kayers had a heart attack if he had a 5% infection rate. Heard of it? I don't know if anyone's fully said why. The skin there is different than the skin that we typically operate on. It's a little more tenuous. So we talk about infection rates, I really should say wound complication rates. Sometimes it is wound breakdown, sometimes it's gross infection. But I don't know, is there a better explanation for it than that? Why we have higher infections around the Achilles? It is the stinky foot, I don't know.
I think the blood supply in that area is not great.
Not as good.
Not as good. It's not as good, and it's not as good. It's under some sort of tension, and so I think that area, I think it's just prone to problems.